Hello again, everyone. This is Adam, and today we're going to be finishing up our discussion on emergency medicine pharmacology. This is the second portion of this. Just FYI, I actually uploaded new copies of the slides to the website and a couple of edits from what was originally uploaded there. So I broke it up into two sets of slides. The first one will be what we covered on class on Monday, and then the second set will be what we cover here today. So just FYI, essentially I had to update a few charts based on some changes to the ACLS guidelines. So just be aware of that and download new copies if you have not done so already. All right, thanks. First thing we'll be talking about today is going to be advanced cardiac life support, covering some of the medications they'll be using for this, along with when it's appropriate to use them and what order you're going to be using these medications. So with ACLS, the medications we're going to cover are going to include the medications listed here. These are the most common ones you're going to see being utilized for the treatment of patients who are in cardiac arrest or in various other arrhythmias. We'll kind of go more into these in detail as we go along. First things first, though, one of the big things I always see people kind of struggle with the first time they ever attend a code is how in the heck do I get drug out of the syringe? These are a particular type of product called a Bristojet or an Abiject. You might see them being called alternatively. And essentially, these are products that are basically, you can see on the right side, you have a vial of drug that has this kind of rubber stopper. That's a blue section there, and then you have the barrel of the syringe on the left side. And so that green bit there on the end is a lure lock, which will connect to things like IV lines and things like that. But if you pull the green part off, it actually has a needle on the end of it. So you could actually end up giving this without having to connect to a lure lock if you needed to. And so one of the biggest things I always see people struggle with is how to actually get drug out of that actual syringe, just due to the fact that it can be a little cumbersome the first time you pop one of these things open. So again, the vials here are kind of calibrated. They are made of glass too, so you don't want to drop these because you can end up having drug kind of spilling everywhere. But essentially, you can give, partial bits of a dose out of this, but usually what you end up seeing is that the doses are calibrated such that for an adult patient, you're going to end up giving the entire amount of the drug. So for instance, like in epinephrine, if you had a patient in a code, those doses the syringe is already in 1 milligram increments, so you can just give the full milligram and be done with it. Versus with like a pediatric code, you would end up needing to get just a portion of the drug out of that syringe, and so that can be a little bit more difficult, especially when you're in kind of a heated situation. You're basically just trying to push a drug out of this. So usually it's a lot better to draw the drug out of this. So you use that lure lock connection on that green end there to actually attach it to another syringe and pull your dose out. That way you can make sure you're getting an actual patient-specific dose rather than trying to play guesswork by kind of connecting the full dose amount and trying to figure it out from there. Because there's been situations where people have actually given way too much drug to peds patients based on kind of miscalculating how much they're actually pushing. But essentially what you have to do is there is basically two ends of the box, as most boxes there are, but one of them says open from here. That's obviously the one you want to open from. So when you do that, you'll notice that the barrel and the syringe full of drug is actually going to come out quite nicely. If you actually open it up from the other end, and I've seen plenty of people do this wrong the first time, the box is designed so that the product actually won't come out that way. So you'll be sitting there trying to shake it out, and nothing's going to come out. So if you open it from the correct end, the drug and the syringe is going to come out of the box. You can then pop off your yellow caps there. Make sure to do that first, otherwise nothing's going to connect. And then you basically screw in the syringe into the vial of the drug. And then once you have that connected, then you're able to connect it to your patient and then push it in from there. So again, just kind of a pictorial example here. Get my laser pointer out. Looking here, you can see how you actually will connect the vial of drug to the actual syringe. You just twist that in. You don't want to push it in because it can actually cause some misalignment and prevent you from actually having the drug go in there. There's actually a small needle in the barrel of the syringe that will actually pierce into the vial of drug there. And then basically you're ready to go. So you can expel any extra air and just go ahead and push it straight to the patient, however you end up connecting it. So the first section we'll talk about are going to be drugs used to treat bradycardia. So this would be for patients who are having non-perfusing rhythms with heart rates less than 60 beats per minute. The first drug we're going to talk about here is going to be epinephrine. This one you're going to see being utilized pretty frequently in the ACLS algorithms. Certainly you'll see epinephrine being used for both bradyarrhythmias and also tachyarrhythmias as well. So we'll see that as we get later on into the talk. But essentially, epinephrine, everyone's body makes this. It's an endogenous catecholamine, and so it's going to work by both stimulating the alpha receptors, which we remember are going to be on the peripheral vasculature and cause some squeeze there, and also on the beta receptors. And this is going to be good stimulation on the heart. It's going to start to kick up those secondary messengers, things like cyclic AMP, and help to increase heart rate. It's going to increase blood pressure and also coronary perfusion, which in a lot of these cases is going to be lacking based on whatever type of arrhythmia you're in. It's not perfusing well to keep those vital organs full of oxygen. The typical indications you're going to see for epinephrine are going to be symptomatic bradycardia with a heart rate less than 60, and especially with that poor perfusion to go along with that. And then also for cardiac arrest. So if you were to have a patient with VFib, VTAC, asystole, or pulseless electrical activity, or PEA, those would be your indications to utilize epinephrine. So again, don't get too hung up on the doses here, but just realize that there is a difference between the doses utilized for different routes of administration. So we'll talk more about those different routes in a second here, but you'll see at first, you're going to be dosing 0.01 milligrams per kilogram IV, or you could potentially give it IO if needed, and basically you repeat your dose every 3 to 5 minutes or so, depending on what type of arrhythmia that you are treating. That ends up being 0.1 ml per kilogram of a 1 to 10,000 solution. And I'll talk more about those concentrations and what that means in just a second, but just know that this can be a source for confusion and can be issues with when actually dosing epinephrine. But essentially your max dose you're going to be administering is going to be 1 milligram per dose. So like I said, a lot of those Abijax or Bristojet are already filled with 1 milligram of the drug. So basically for an adult, you just push the whole thing and you're kind of done. So it's pretty convenient from that standpoint. Notice here for endotracheal tube dosing, so again, this would be a direct installation of the drug down the endotracheal tube. It's 0.1 milligrams per kilogram, so about 10-fold increase in dose there when given via the ET route. And again, you'd be giving that every 3 to 5 minutes. Again, this is typically you see ET tube being utilized as a route when other access is not available. So if you don't have an IV or an IO route available, and notice here that you're going to be using 0.1 ml per kilogram of 1 to 1,000 solution. So you see here 2 different concentrations, but you're given the same volume, even though you're getting a 10-fold different dose. So obviously there's lots of room for confusion here. We'll talk more about that. But your max ET2 dose is actually going to be 2.5 milligrams per dose. So notice, or just looking at this, you can kind of tell that your bioavailability via the ET route is obviously going to be less because you're having to give more drug in order to get the same equivalent amount absorbed. So in regards to epinephrine concentrations, you'll oftentimes see this kind of nomenclature that I believe is starting to go by the wayside a little bit. I think there's going to be some new regulations that prevent companies from actually marketing the drug as this concentration, but you'll see things like 1 to 1,000 or 1 to 10,000 concentrations, and it's very old school nomenclature, but essentially what it means is that for every 1 gram of drug, you have 1,000 mLs. For the 1 to 1,000 concentration. So basically what that means is you have 1 milligram for every 1 ml. So the way I think about that is I just take off the 3 zeros at the end of that ratio there, so I have 1 milligram to 1 ml. And similarly, when you have 1 gram per 10,000 mLs, you have 1 milligram in 10 mLs. You can just knock off those 3 zeros. So similarly, if you had a 1 to 100,000 solution, it'd be 1 milligram in every 100 mLs. So this is important because you don't want to get this screwed up, because wrong concentrations can either be ineffectual if you're given too dilute of a concentration, so your patient's not getting better even though you're giving drug, it's because you're not giving enough, or if you give too much and give the wrong concentration, it can lead to things like cerebrovascular accidents or hemorrhage, because when you give epinephrine, because it is such a potent vasoconstrictor, if you constrict the vessels in the brain hard enough, they eventually can cut off blood flow and lead to stroke. So there's been numerous case reports of this happening where people are given the wrong concentration, so it's something to definitely be aware of. I'll say that typically when you're giving epinephrine in the IV formulation, you typically want to use a less concentrated variety. So that's why most often when you give IV, you're using the 1 to 10,000 solution, or basically you have 0.1 milligram for every 1 ml. Versus if you're giving something that you either need to use a higher dose, such as like an ET tube dosing, or if you're giving something where you need to give it a small volume. So like if you're doing intramuscular epinephrine for anaphylaxis, you'd want to use a more concentrated 1 to 1,000 solution for that. So just a note on endotracheal tube dosing. So typically this is only going to be performed when you don't have IV access. I'll tell you that a lot of places are getting easier access to intraosseous kits where you can actually just drill down into the tibia most frequently, and basically into the basically the marrow, and that way you can provide as much drug through that as possible. It's basically like a big non-compressible vein at that point. But if you didn't have any other form of intravenous access, you could certainly use the endotracheal tube. Again, because you're having less absorption of the drug, you're having less bioavailability, you typically need to use 2 to 2.5 times the IV dose. However, as you saw with epinephrine, you need around 10 times the dose. But you saw that the max dose between the two is roughly 2.5 times. So, max dose for epinephrine IV is 1 milligram, whereas endotracheal tube dosing is 2.5 milligrams. A good mnemonic to remember which drugs can be given via the endotracheal tube is lean. So lidocaine, epinephrine, atropine, and naloxone. You guys remember naloxone being the opioid antagonist to block the effects of the mu receptor. Kind of talked about the other three recently as well. Again, rarely is it being done, if ever, just because of the fact that you typically have a lot better ways to get access intravenously than having to resort to ET tube dosing. So again, just something to be aware of. So next, looking at atropine, typically this is going to be coming in a concentration of 0.1 milligram per ml. Again, this comes in a one of those Abijex or Bristojet kind of pre-filled syringes. So basically you have 1 milligram in an entire 10 ml syringe. So that's a very common concentration there. Now we know that this one is a muscarinic receptor antagonist, which means it's going to be vagolytic. And so by blocking the muscarinic receptors on the heart, you're going to see an increase in AV conduction and also in heart rate. Really, insofar as its use, it used to be used for cardiac arrest. So essentially the old algorithms where you'd switch between epinephrine and atropine. But nowadays, it's not really recommended for cardiac arrest, but it is recommended for symptomatic bradycardia. So especially if it's being mediated by an AV block or vagally mediated, this is certainly where it would get most of its use. Obviously, if it was an issue of bradycardia caused by, say, like a beta blocker overdose, it may not be working quite so effectively, but it's certainly worth a try and can lead to some temporary effects to increase that increase heart rate and maybe increase your cardiac output as well. The dose you typically see being used for atropine is 0.02 milligrams per kilogram IV. And again, similar to epinephrine, you'd repeat this around every 3 to 5 minutes or so. Kind of the newer recommendations are to use lower doses of atropine, so you end up actually maxing out at around 0.5 milligrams per dose, as opposed to the full milligram that you end up having in those pre-filled syringes. So again, something you're not going to see quite so much, especially in like cardiac arrest, but certainly for symptomatic bradycardia, this would be the way to do it. There is a concern of actually in very small children having this issue of paradoxical bradycardia. So some people will actually recommend using 0.1 milligrams as a minimum dose. If you went below that, you can actually cause the patient to become more bradycardic. Well, actually, it's not really supported in the medical literature. So if you ever hear about it, it's not really something done nowadays. And actually, in very, very young kids, so say if they're only, say a few kilograms big, you can actually lead to a pretty big overdose for those patients. It may lead to some anticholinergic poisoning. So from that standpoint, really just stick to your weight-based dosing, that 0.02 milligrams per kilogram, and don't really worry about the minimum dose. So those are the two main drugs you'll see being utilized for symptomatic bradycardia. Moving on, we'll talk about our drugs for tachycardias. The first one we'll see being utilized is adenosine. This is as you might imagine, it's an adenosine receptor agonist. So we have adenosine receptors all over the body, including on the heart and also on the brain as well. So adenosine is basically kind of acts very similar to GABA in the way that's kind of like a brakes on the system. So for instance, in the CNS, if I had something that was an adenosine receptor antagonist, it actually ends up being kind of more stimulatory. So a good example of this would be caffeine, and can actually lead to seizures that can occur. So here, though, we see adenosine receptor agonist by giving adenosine, and what you end up having is basically kind of trying to stop all activity. So what this drug does in the heart, though, it actually causes a temporary AV node conduction block. And so this can help to interrupt reentry circuits that are happening there. So the big indication you're going to see adenosine used for, this is kind of the only indication, is going to be for supraventricular tachycardia. So if they have these kind of reentrant rhythms, they have their heart rate up in, say, the 180s up to 200 maybe. Some kids it's up to like 220 in some cases. So very, very fast heart rates. And essentially by giving this, you basically kind of stop the heart for a second, and then hopefully it'll interrupt that rhythm, and then the heart can start conducting appropriately again. So it's actually very dramatic when you see it. Usually these patients will have a continuous EKG on. And so when you give this and you push it correctly, you'll actually end up seeing the heart kind of stop for just a second and then come right back. So it's very, very cool to see it being given in person. Typically, you see the dosing starting off as 0.1 milligrams per kilogram as the first dose, and you use it kind of up to a max of 6, and then you can repeat that as a second dose if the first one was not effective. The big thing you have to remember with adenosine, this is really important for this drug, is it's a very short half-life, so say less than 10 seconds or so. And so what can happen is if you give it, especially in a peripheral IV, if you don't push it fast enough, you actually have the potential to degrade it before actually reaching the heart. This means that, if I give a 6 milligram dose, but I don't push it fast enough, it might degrade before it gets to the heart, and I'll say, basically won't be very effective. I might have to give a bigger dose just to actually get there. So what you end up having to do is flushing immediately with saline right afterwards in order to help push the drug faster through the veins to the heart. And so what you end up doing is having to do this with kind of 2 syringe setup with this with like a T connector or a stopcock. And basically what you end up doing is you hook one end up to the patient. You have one end with your adenosine in it pre-drawn up into a syringe, and then you have another, the other end is going to be your syringe full of saline. And so essentially what you end up doing is very quickly kind of push adenosine, saline, in order to help facilitate getting that drug to the heart as quick as possible. So if you do it correctly and have the good setup, it can lead to a pretty effective drug. Otherwise, you may need to repeat your doses and use higher ones in order to get it to be effective. Moving on, then we have amiodarone. So this is one we've talked about before, and this is one of the mainstays of antiarrhythmic therapy in ACLS. So adenosine is a class 3 antiarrhythmic, has lots of different actions by blocking things like potassium channels and calcium channels, sodium channels. And what this is going to help us do is help to slow ventricular conduction. So the main uses we're going to see for it is typically if you have an SVT that's unresponsive to adenosine, you can utilize amiodarone to help slow down that conduction, hope to interrupt that reentrant rhythm. For wide complex tachycardias, and then where the most often you're going to see it is for ventricular fibrillation or tachycardia. This is a very effective drug for kind of terminating those arrhythmias, hopefully getting your patient back to spontaneous circulation. This drug can be bolused multiple times, and as we remember, amiodarone has a very, very long half-life. If you were just using maintenance dosing, it can take months and months before you'd actually ever get to steady state. So this drug is really important to remember that you're going to bolus up front, so you can repeat it a few times if you need to in order to get good control of the arrhythmia. And then you have to follow it up with a drip afterwards in order to help maintain that steady state that you've reached by giving the boluses. So again, it's one of those things where you push the drug and everything's looking good. You terminated the arrhythmia, but then you have to remember to put the drip back on, because otherwise the rhythm could come right back once the drug levels start to drop. Typically, if you give this drug too quickly, especially to a person with a perfusing rhythm, you really have to watch for hypotension or bradycardia that can happen. So for this one, you typically want to give it over a longer period of time. However, if they don't have any kind of rhythm and they're not perfusing at all, you need to get that drug to the heart as soon as possible. So in which case, you can actually give it IV push. Again, at that point, you're kind of doing compressions for them to help try to circulate things. So you need to give it as fast as possible in order to try to have the biggest chance for the drug to get to the heart to work. Moving on, then you have lidocaine, which is kind of an alternative antiarrhythmic. It used to be used a lot more as kind of first line, but it's kind of taken a back seat to amiodarone. As we remember, it's a class 1B antiarrhythmic, so it's going to be blocking those myocardial sodium channels, and by doing that, it's going to help to suppress ventricular arrhythmias. Again, the most often the indication you're going to see it used for is VFib and VTAC, and certainly can be used if amiodarone is not available, or if amiodarone has not been successful, you may potentially use lidocaine as a backup method. And then the biggest things to worry about with lidocaine is that it is renally and hepatically cleared. So you have to remember that for those patients who have significant dysfunction, they're going to have decreased clearance, which means they can have increased chances for toxicity. Namely, CNS toxicity is going to be probably the biggest one you're going to see here if they're not able to clear the drug very well. So things like hallucinations, seizures certainly could occur. This is going to be another drug that you're going to see utilizing loading dosing up front and then followed up by an infusion. So again, the loading dose helps you get the steady state levels for the drug, and then the infusion kind of keeps the levels at that stable amount, so that way you can help to continue to treat the arrhythmia. Again, typically you're going to be using half of the dose for patients either have like CHF or hepatic impairment, because they're not going to be able to clear the drug very well. So again, just remember those points there. And it can also be given either via IV route or via the intratracheal tube route as well. One of the other drugs we'll see being utilized in cardiac arrest is going to be magnesium. May not think of it as an antiarrhythmic, but it's going to be the drug of choice for treating torsades in these patients. Again, this is one of those things that you don't typically want to give IV push in patients who are awake and perfusing, but you can be given push in the setting of a code. So if they were, unconscious and were in non-perfusing rhythm, certainly you can push this drug. The big thing to remember with magnesium is that it is kind of like a natural calcium channel blocker in the body. So because of that, very similar to what you would see with something like say like a dihydropyridine calcium channel blocker, is you're going to see that vasodilation that can occur, especially when giving it too quickly. So certainly flushing and hypotension can happen when giving magnesium too fast. Other drugs that we can see utilized very frequently in advanced cardiac life support is going to be sodium bicarbonate. Sodium bicarbonate is great to use in many different circumstances, so certainly things like hyperkalemia, so we'll talk about in just a little bit. Also in certain poisonings as well, so you can utilize it for things like aspirin poisoning or tricyclic antidepressant poisoning. And essentially what you end up seeing utilized is a 1 milliequivalent per kilogram dose IV. But the big thing to remember this one is that oftentimes in code carts, what you're going to see is that you have two concentrations available to you. So either a 4.2% or an 8.4%. That's going to make a big difference in the concentrations here, because one's going to be 0.5 milliequivalents per ml, the other one's 1 milliequivalent per ml. So that means if you grab the wrong concentration, you're either going to give double the dose or only half the dose that you want. So it's really important to be sure that you say, okay, I'd like 50 milliequivalents of sodium bicarbonate, instead of just saying, well, give me an amp of sodium bicarb, right? It's important to be very clear on what you mean when you're saying these doses here. The only adverse reactions you really worry about with sodium bicarb is that due to the effects that the sodium bicarb will have on your ionized calcium, it can temporarily drop it. You can't see tetany due to this kind of transient hypocalcemia that will occur. Again, total body calcium has not gone down, but you will see it very transiently. Your ionized calcium will dip down. Calcium is also commonly found in code carts, so you'll see the main indications being for obviously hypocalcemia, which you can see especially in massive transfusions. So patients who are getting like large numbers of units of blood. So say if you're working in a trauma center and a patient's coming in who had was profusely bleeding, they need several units of blood to help restore that their blood volume. One of the big things you see is that citrate is utilized as an anticoagulant to keep that donor blood from clotting up. So citrate will basically keep calcium in that blood from causing it to coagulate. So the same thing happens when they get all the citrate infused into them, is they're going to have hypocalcemia. So you may need to give calcium along with those transfusions in order to help prevent that from occurring. Calcium also is useful to help stabilize the myocardial membrane, and so that's going to be important for hyperkalemia because it can actually help to prevent an arrhythmia from beginning by giving this in the setting of high potassium levels. You'll typically see there's two different salts of calcium that are available, either gluconate or calcium chloride. And so the big differences you're going to be seeing here, and if you look at the vials that are available, you see calcium chloride is available as a 10% solution in a 1 gram vial, and you'll see calcium gluconate is also in a 10% solution in a 1 gram vial. But you need to remember that the gluconate molecule is a lot bigger than a chloride molecule. And so because of that, the elemental amount of calcium is going to differ between those two products. So if you look at calcium gluconate, there's roughly 1/3 of the amount of elemental calcium for every gram as compared to calcium chloride. So what that means is you need 3 grams of calcium gluconate to equal 1 gram of calcium chloride. So it's really important to keep that in mind when you're doing your dosing, because you want to make sure that you're giving an equivalent amount of calcium. So if you look at the different dosing here, you can see that roughly gluconate dosing is going to be at least 3 times what the dosing is for chloride. So again, the max dose for calcium chloride is 1 gram versus 3 grams for gluconate. So again, you're essentially giving the same amount of calcium, just with a different amount of the salt form there. Big thing to remember here is that gluconate is also going to be a lot easier on the veins. You really worry about the calcium chloride, as it's very, very rough on the veins. It can cause thrombophlebitis, can extravasate, cause tissue necrosis. So it's really preferred, if you can, to either use a very dilute concentration or to give it in a central line. Because otherwise, if you extravasate that calcium chloride, it can cause some big, big issues down the road. Calcium gluconate, though, is much more soluble. It's going to be much easier on the veins, and so that's typically going to be the preferred one to give if you only have, say, peripheral access. Naloxone is also a common drug you'll see in most code carts. It's helped to utilize or to be utilized to reverse opioid intoxication. So again, it's going to help to competitively inhibit those mu opioid receptors, and so it's going to be able to help reverse a lot of the CNS and respiratory depression. So it's really cool if you ever see someone who is completely zonked out on opioids. Give them a dose of naloxone and they will wake up within seconds. It's actually pretty incredible. It's like seeing someone come back from the dead almost. Big thing you have to worry about, though, is that especially if you have someone who's opioid tolerant or has been on opioids for a long time, you run the risk of putting them into withdrawal. So that can be really interesting to see them wake up and be completely, go from comatose to wide awake in a second. But it's also not too fun to have to deal with them once they're awake, because again, they're going to be feeling miserable. They're going to be making everyone else's life a pain, and your nurses probably aren't going to like you too much. So again, it's really important to start with low doses and try to titrate up to effect, especially in your patients who you feel might be opioid dependent. Dextrose is also available, so certainly your indications are going to be for hypoglycemia. Again, it could be a very common cause for ultramental status, so it's always good to check an AccuCheck and see if you need to administer this. Looking at the different concentrations that are available, you can see that the common ones are going to be 10%, 25%, and 50%. Keep in mind that dextrose in increasing concentrations is going to have an increased osmolarity, and this will be more irritating to the veins. So that's why you typically see different dosing ranges or different concentrations utilized for different ages. So say, for instance, you have, say, a 1-year-old, you're going to be better off by giving 10% dextrose, because of the fact that it's going to be a lot easier on their small veins. Versus with adults, if they're severely hypoglycemic, I can push D50 and get away with that. Other big thing to look at, though, is that your volumes of drugs you're going to be giving change depending on the concentration. So say, for instance, I'm going to be giving a 1 gram per kilogram dose of dextrose. Well, for D50, that means 2 mLs per kilogram. Versus if I was giving D10, I need to give 5 times more volume in order to get that into the patient, that same amount of dextrose. So that can be a problem for patients who have, say, like renal impairment or hepatic impairment, have a lot of fluid overload anyway. It can end up being quite a bit of volume. So typically, if you're worried about volume issues, you can utilize a higher concentration in order to get that amount of dextrose you need into them. Obviously, a lot of the irritating effects can be mitigated if you're giving it via a central line. So here's the algorithm for treatment of cardiac arrest. This is actually the most up-to-date 2015 update they'll be talking about here. So essentially these are meant to be pretty simple and straightforward for the most part. At least drug-wise, it's fairly easy. So the big things you want to focus on are going to be use of epinephrine. So think here, you're going to be starting CPR. You know, so you have someone who's in cardiac arrest. You look to see if it's a shockable rhythm or not. So asystole, PEA are non-shockable rhythms. They don't really respond to cardioversion. And so essentially you'll end up going down this one pathway where you're just giving rounds of CPR every 2 minutes and then giving epinephrine doses every 3 to 5 minutes. Again, for adults, you end up usually giving the max of 1 milligram there. Again, you're just going to keep continually reassessing to see if you need to, if they kind of turn into a shockable rhythm or not, and then just continue your doses of epinephrine. Because if you go down the other pathway where it's VFib or VTAC, again, you're going to be shocking them, again, assessing for return to spontaneous circulation between here, but certainly keeping up your CPR. Again, you'll see the only drug you're really going to use here is going to be epinephrine. So if that fails to respond to shocking, essentially what if it fails to respond to defibrillation, eventually what it goes down to is trying to use amiodarone as kind of a chemical way to help reverse the VFib or VTAC. So it's really only the second medication that really pops in here into this algorithm. But certainly if it's asystole or PEA, just epi every 3 to 5 minutes or so. It's pretty straightforward. Used to be other drugs on this algorithm. Used to switch between epi and atropine, but atropine was taken away, I believe, in the 2010 updates to ACLS, and then with the 2015 update, which is brand new, they actually removed vasopressin. You remember vasopressin we talked about in our nephrology section. Essentially what they would do is if you had a patient who is in cardiac arrest, you would give your first dose of epinephrine, and as an option, you can give a second dose. When you would have used your second dose of epinephrine, you could do a dose of vasopressin. You'd use 40 units or so. Again, no real studies actually support that, so they ended up removing that from the algorithm. So it's just epi, and then if they have VFib or VTAC that's not responding to the defibrillation, they'll just utilize amiodarone. So the big things there. Moving on, looking at adult tachycardia, I see that it's still pretty straightforward. Again, looking at tachyarrhythmias being heart rates over 150. Essentially, you want to be looking to treat any of the underlying causes that are being issues here. So again, give them oxygen if they're hypoxemic. Check their blood glucose if that's an issue. And then essentially you're looking at their rhythm, looking at blood pressure, looking at how well they're perfusing, and so you want to see if whether or not it's kind of a stable or unstable kind of tachyarrhythmia. So are they hypotensive? Do they have an altered mental status secondary to this? Or signs of shock? If yes, then you're going to straight go over to synchronized cardioversion. If it's in regular narrow complex, you can consider adenosine, but typically if they're that unstable, you're going to go straight to cardioversion in most cases. However, though, if they are stable, then you need to look and see how wide their QRS is. So look to see if they have a widened QRS. If yes, you can also consider adenosine only if it's regular and monomorphic. But essentially, the drugs you're going to go with are going to be some antiarrhythmic. So some of the ones we've talked about before include amiodarone, probably your most common one, but certainly other agents like procainamide or sotalol can be utilized as well. Remember, sotalol is going to be a beta blocker, but it will prolong QTs in some cases. So if your patient already had a prolonged QT to begin with, this would be a drug you probably want to avoid. On the other hand, if it's a narrow complex tachyarrhythmia, that's when you can consider, if it's regular, utilizing adenosine. So this is going to be mainly your SVTs you're dealing with there. And then also if that fails, you can potentially consider utilizing like a beta blocker or calcium channel blocker. Here you'd be utilizing your non-dihydropyridines. So that would include diltiazem and verapamil in this case. You wouldn't want to use something like nicardipine because that's going to be working much more on the vasculature more than anything else. And then looking at bradycardias, so again, this is going to be typically heart rates less than 50 in most cases where some signs of poor perfusion. Again, you want to treat the underlying causes if any are available. And really the big things you're going to be looking at are using atropine. Is going to be probably your first stop. Most people don't necessarily jump straight to epinephrine, but certainly if atropine is ineffective, you can consider doing either like a dopamine infusion as a pressor or as an epinephrine infusion. So usually, unless they're really symptomatic, and the atropine's not working, would you use like an IV bolus dose of epinephrine? But it's pretty rare for the most part. Usually you're going to see your bolus doses of epinephrine being utilized more for true cardiac arrest. So one of the things that people have a lot of apprehension with is running codes with pediatric patients, especially if you work in a mainly adult facility. The second you hear about a peds code coming in, like, you're going to freak out. Most people do. It's very common to be very uncomfortable with that. And so when you have one of these patients who are coming in, especially if you're not comfortable with them, you don't want to be sitting there trying to calculate what dose to give, and then based on the dose of milligrams per kilogram, how much volume you want to give based on the concentration of the drug that you have. So really you want to be prepared beforehand whenever possible. So a lot of places will end up having books where they have code sheets, and essentially they're designed for a specific patient weight. So you'll have a sheet for a 1 kilogram kid all the way up through, say, a 50 kilogram kid. And really, a lot of them should have commonly used resuscitation and intubation medications. So things like, your etomidate, your succinylcholine, your epinephrine, your atropine. The idea here is that in the heat of the moment, you're not stuck doing calculations, because again, that's when your heart's racing, adrenaline's going, and you're probably not going to be making the best sound judgments at that point. The other big thing is the volumes are going to be listed. That's very easy. It's easy to say, well, give 0.2 milligrams of epinephrine, but how much volume are you going to give? Having to figure that out during the situation would be pretty tough. One other thing to remember if you're ever dealing with a peds cardiac arrest is that if the patient's kind of between weights, so say you have code sheets for 20 kilograms and 25 kilograms, your kid comes in, he's 23. You generally want to round up because you'd rather end up giving a little more drug in those situations than less. Here's a good example of a code sheet. This is actually what we use at Nemours. You can see here that all the basic drugs we kind of talked about already are listed here, including the dose that you're going to administer based on, in this case, a 10 kilogram kid, and then actually how much volume you're going to be administering as well. So it makes it very nice and easy, so that way you have less actual calculations that you're performing. You really shouldn't be doing any. And when the provider or you decide, hey, I want to give a dose of atropine, you know exactly how much that kid's going to get. Here'd be an example of like the RSI drugs. We talked about atropine, lidocaine, etomidate, succinylcholine. So those are all main drugs you see being utilized. You also see like fentanyl and Versed. We've talked a little bit about previously as alternative agents. Another big thing you'll see utilized in a lot of situations is going to be the Broselow tape. So this is essentially, if you didn't have an actual weight on a kid, you could basically use the length of the child to figure out what kind of rate range they should be in. So say for instance here you have a child who you basically lay them out flat on the stretcher, and then based on where their feet end up on the sheet, they have a certain color. So you can see on this kid here, he's kind of bordering between a white and a yellow. So you can say, well, it looks like he's probably in the yellow phase, or in the yellow category. So we're going to assume he's between 12 and 14 kilograms. And that way you can actually make your dosing decisions based on that. Obviously, it's going to be a big problem when you're dealing with kids who are extremely underweight or kids who are extremely overweight, because your calculations are based off kind of false assumptions at that point. But it can be handy to utilize if you are in a place where you can't really get a good weight on the kid. Maybe family's not around to give you a last weight recorded, things like that. So it can be useful in a pinch. Other tips that you want to look at for having a safe resuscitative experience. Usually you'll find a physician who's going to be running most of these codes. You always want to make sure we're calling back the order. We want to make sure we're practicing good closed loop communication where say the provider says, hey, I want 1 milligram of epinephrine, 1 to 10,000. You repeat that back to the physician to make sure that's exactly what they want. So you need to be really precise in this. So I always hear things like, I gave an amp of calcium. Well, what does that really mean? Did you give calcium gluconate? Did you give chloride? How much is actually in that amp? How many mLs of volume did you actually give? That can all mean very different things depending on what you're talking about. And then you always want to use units. So something like start dopamine at 5. What do you mean? Do you mean 5 micrograms per kilogram per minute or 5 milligrams per kilogram per hour? Because I'll tell you, those are very different rates. I know in one case we had a patient who's going to be started on a nitroglycerin drip, and the nurse got the units wrong. The doc said, hey, start at 20. And so the nurse ended up infusing it far too fast because they did it, say, mics per kilo per minute rather than mics per kilo per hour. Ended up infusing the entire bottle of nitroglycerin to that patient within maybe 20 minutes, and it should have been a bottle that lasted them several hours. So patients complain of a really rocking headache because all their blood vessels are extremely dilated. They end up doing okay, but still is an example of a pretty significant med error that can occur when you're not using precise language in good closed-loop communication. So moving on, we'll talk about another emergency situation, being hyperkalemia. So potassium, we know that has a very high intracellular to extracellular ratio, around 98% on the intracellular side versus 2% on the outside. And we know that it's really important for regulating a lot of the function of excitable tissues. Mainly the heart is a big thing we're going to be looking at here. And even slight changes can really result in pretty large effects on excitable tissue. Usually we like to keep a nice narrow range between 3.5 to 5 milliequivalents per liter, and it's important to realize that it's almost entirely excreted by the kidney, so it's really the only way it's going to get eliminated from the body. So because of that, you can see that obviously patients who have kidney issues are going to be more likely to hold on to more potassium. Most commonly, you're going to see hyperkalemia is going to be caused by some degree of renal dysfunction. So that can be, brought on by increased intake of potassium. I know there's some salt supplements or salt replacement items out there that instead of getting sodium, it would actually be potassium-based salts. So, if you have a renal dysfunction and you're not able to clear potassium appropriately, this can be a big increased intake for you. It can lead to some issues. Other drug-induced causes of hyperkalemia could certainly include things like your NSAIDs or ACE inhibitors. We know that anything blocking the effects of aldosterone are going to increase the amount of potassium within the serum. So ACE inhibitors, ARBs, things like spironolactone, potassium-sparing diuretics, all those things are going to be working to increase potassium levels here. So lots of different causes for hyperkalemia, or it could just be a gradual renal dysfunction over time. They're not able to properly process a lot of that, so it could be due to other causes than just their renal dysfunction. What you end up seeing, the big things that we worry about, the cardiac effects. It's going to help to slow ventricular conduction. It's going to shorten the action potentials. And so on the EKG, you typically see things like peak T waves and widened QRS. And so VFib and asystole are going to be the big things that we're worried about there. On the neuromuscular side, you might see some other things pop up that may be kind of warning signs. So certainly paresthesias and weakness can be important signs of impending issues with high potassium levels. The way that I remember the treatment for hyperkalemia is this mnemonic I use called C-A big K drop. A resident taught me that one time, and I never forgot how to treat hyperkalemia since then. The big things you're going to be giving here are going to be calcium, albuterol, then you have bicarbonate, insulin, glucose. Then we have a drug called K-exalate, and then finally dialysis. So CA, big K drop is the way I remember that in regards to the different therapies that you're going to utilize to help bring their levels of potassium down. So calcium is going to be utilized to help basically reduce that threshold potential for the cardiac myocytes. So it helps to kind of restore that resting membrane potential and prevents the heart from being too excitable and going into a dysrhythmia. So it can be beneficial even in normal calcemic patients. So even if their calcium is relatively normal, you can still give it to them to help stabilize that membrane. This is a temporary measure, so it usually has a short duration of action because, especially if your patients can clear the calcium fine on their own, their body's going to be able to process that pretty well. And so maybe 60 minutes later, you're not really going to see much effect from that calcium. Keep in mind here that if they are in a perfusing rhythm, probably you'd like to give calcium gluconate if possible, mainly because it's easier on the veins, but certainly they had some sort of central access. Calcium chloride could be utilized as well. The next thing we can do, besides just stabilize that membrane potential, is we can actually shift potassium into the cells. So the couple drugs that we can use that to do that. First one going to be our beta receptor agonist. So albuterol is going to be the big one here. So this is beneficial for patients who are without IV access. So this is good if you have a patient rolling in via EMS. You can slap an albuterol neb on them fairly quick while you work on getting IV access. In some cases, you can even use continuous nebulization here in order to provide continuous effect. Obviously, with albuterol, the biggest things you worry about are going to be tachycardia and tremor, but certainly could be better than the fatal arrhythmias that could develop from the potassium. Keep in mind, patients who are on beta blockers may be kind of resistant to this, so you may need to you may see more or less effect based on what other drugs they may be on. Certainly, albuterol is probably the kind of least effective, mainly because this is not like a nice potent IV agent, but it can kind of do the job while you work on getting better access. Bicarbonate is going to be important as well, especially if you have a patient who's acidotic. We know that the more acidotic you become, the more potassium shifts outside of the cells. So by giving bicarbonate, by alkalizing the serum, you end up causing it to shift back into the cells. Again, keep in mind that whenever we're shifting potassium around, we're not actually getting rid of the total body burden of it. We're just kind of temporarily storing it away, so it's not going to be having such an effect on the heart. So again, these are temporary measures until you can actually get rid of the potassium. Typical doses, 1 milliequivalent per kilogram, and that's going to help to kind of stabilize things and move potassium back in. So you'll see that temporary shift occur if you were to look at like serial basic metabolic panels. Another set of drugs we can use to shift potassium into the cells is going to be insulin and glucose. Again, we know that by activating those GLUT transporters, insulin making those GLUT transporters more present, it's going to start to activate that sodium-potassium ATPase pump. So essentially, by activating that, it's going to start to bring potassium into the cells and shift that intracellularly. Note here that you're generally going to be using really only regular insulin that is used most often. This is typically IV. So for like an adult, you use 10 units of regular insulin along with some dextrose. Remember, you always want to add the dextrose onto that, otherwise they can become hypoglycemic. And that's usually enough to kind of get them started to shift that potassium in. Some cases, though, you may need dextrose infusions, especially if they are fairly sensitive to the effects of insulin. So that could be something to remember there. The next modality you'd want to try to use is to eliminate potassium from the body, right? So we've found things that make the heart more resistant to arrhythmias. We've found things that shift potassium into cells, but now we want to get rid of the potassium if we can. Diuretics may be a first thought, but really the kidneys are going to be they're kind of a questionable benefit. You don't really get much bang out of your buck, although certainly they would not hurt anything in the acute phase. But other things are going to be a big help here are, one, an exchange resin called sodium polystyrene sulfonate, or SPS, or otherwise that was known K-exylate. This is actually a cation exchange resin. So you can either give this orally. If your patient can't tolerate it orally, you can give it rectally. And basically what it does is it sits in the GI tract and actually will exchange sodium, taking sodium into the body while pulling potassium out. And once it binds to that resin, it ends up getting eliminated through the feces. So you'll see some patients who will end up being on this kind of around the clock, so say every 6 hours or so, especially the kind of chronic hyperkalemia. You see that a lot in renal patients. But it can be used acutely in order to help bring that potassium down. Note, this is probably the slowest method to actually eliminate potassium from the body, so it's going to take time. You can give them a dose, but if you need it emergently to get rid of that potassium, this is not going to be the fastest way to get rid of that. As far as side effects go, constipation is probably going to be the most common one with this medication. And then finally, the fastest way to get rid of potassium is going to be dialysis. So basically giving them a set of artificial kidneys to help filter that out and pull it off. And typically, even within the first 1 to 2 hours of dialysis, you can see a pretty significant fall of your potassium between 1 to 2 milliequivalents per liter. So, pretty effective way to pull off that extra potassium, especially when their kidneys are not working well on their own. And then finally, the last section we'll talk about real quick is going to be treatment of anaphylaxis. So again, another very common emergency you can see coming into the ED. Keep in mind the common players you're going to see being utilized for anaphylaxis treatment. Our first step is going to be your antihistamines. So you can utilize H1 antagonists or H2 antagonists. These are going to be blocking the effects of the endogenous histamine your body's releasing in response to whatever the antigen was that set it off. Your typical drugs you can see utilized are going to be things like diphenhydramine, hydroxyzine, probably more commonly. Some people have even tried using cetirizine for maybe more kind of slight anaphylactoid reactions, but typically if you're having like a full-on anaphylaxis, diphenhydramine is going to be your go-to IV agent here. Because of this excess histamine, some people worry about having increased effects on the GI tract that can lead to some issues. So some people actually give an H2 antagonist along with the H1 antagonist. You'll note that there's not a ton of evidence behind use of this, but it's still routinely done. So certainly ranitidine or Zantac is going to be a pretty common drug to give in that situation. The other two main drugs are going to be utilized to treat anaphylaxis are going to be your corticosteroids and then epinephrine. So corticosteroids, you can either utilize oral or you can use IV. Keep in mind, though, that corticosteroids take time to work. They usually are delayed by several hours in their effect, mainly because they have to get down to the nucleus to go to the steroid receptors to cause gene transcription to change and to have their anti-inflammatory action. So because of that, it doesn't really matter if you give it orally because, again, it takes time for it to work in the first place. So not necessarily as much bang for your buck by giving it IV as you might think. More of the common ones seen utilized in the IV form would be methylprednisolone, or solumedrol, or hydrocortisone, brand name being Solucortef. Orally, you can get away with utilizing either prednisone or prednisolone. The only difference between those drugs is that the prednisolone is the liquid formulation and prednisone is a tablet. The body actually converts prednisone over to prednisolone, so that's actually the active form there. And then epinephrine is going to be your other main drug. This is probably going to be the most effective thing up front, kind of followed shortly behind by your H1 antagonist, and then finally your corticosteroids. So this is the fastest acting, and most commonly you're going to see this being utilized IM. Very rarely do you need to give IV use, maybe if you're in kind of total cardiopulmonary shock, but you really try to utilize IM whenever necessary. This is probably also the most common way that most patients are going to administer it to themselves. So many patients who have known anaphylaxis to things like peanuts or eggs and things like that, they already have EpiPens that they carry around with them, which is basically an auto injector that they can just jam into their thigh. It will automatically inject the drug intramuscularly. You typically want to avoid sub-Q injections, especially during anaphylaxis, because you may not get a whole lot of good absorption there. IM is a much better way to ensure you get good absorption of the drug. And then for those very severe patients who are hypotensive and kind of shocky looking, you may need actual continuous infusions of IV epinephrine in order to help maintain their blood pressure and to treat them through that. So those are the main drugs you'll see utilized in treatment for anaphylaxis. All right, so that's the end of this section. Again, these slides are a little bit updated, so if you did not get the updated section off the course website, please do so. They had the updated ACLS guidelines for 2015 for the cardiac arrest. Again, not a whole lot different there, but mainly just the removal of vasopressin from the drug side. But just to make sure we're keeping up to date, that's going to be there. If you have any questions, please let me know. Otherwise, we'll talk about it in class, and I will see you guys on Monday.